Welcome on this Friday afternoon. Welcome to Ask Dr. Geier Live. Wherever you're watching, hope you're making today your masterpiece. My name is Dr. David Geier, orthopedic surgeon, sports medicine specialist, anti-aging and regenerative medicine expert, and media medical expert. I help you feel and perform your best regardless of age, injuries, medical history, really anything else. I am here that one time a week, the one place that I am here to answer your orthopedic questions. Whether you have a question about surgery, question about the injury itself, about the rehab, the recovery, whatever you want to ask about it, I am happy to. But please remember, I am not giving you medical advice. This is meant for general information and educational purposes only. I haven't seen you, haven't examined you, haven't looked at x-rays, MRIs, any of that. So this is really more meant for information to help you understand your injury or surgery or whatever it is better, and then help you make a decision with your doctor that might be best for you. I'd also love, if you're new to this on YouTube, don't leave your questions, comments, whatever in the comment section. Leave those in the chat. That is the only place I can see them. Also, I'd love to know your first name and where you're located. I think that's always fun. I have heard from a whole bunch of people through various channels this week that they're going to be here. So if they are, fantastic. We're going to have a lot of questions to get to. If we don't, then they had something else they needed to do, and we'll do it another Friday. Also, if you want to see me officially in the office as a real patient, the link to my website's below. Go to the contact page, fill that out, and we can help set that up. All right, Soom Lydia, 12 weeks post meniscus repair. Knee feels so stiff. My walk is slow and I waddle a bit. What might be the cause? Could it be scar tissue? How long will the stiffness last? And then there was another one. What exercises would you recommend to improve my walking gait? Let me do that one. Let's do them in the order that it comes. First of all, and this really gets to, and I don't know in your case, but there is a huge difference in the recovery and in the rehab for a meniscus repair where you sew the meniscus back together with stitches compared to what is the case 98% of the time. Even though people think they had a meniscus repair, the surgeon actually went in there and just cut the torn part of the meniscus out, like I talked about yesterday on Better Than Ever Live. If it's the part that the meniscus was trimmed out, typically stiffness is not an issue. There's no limitations on the range of motion. It's just a matter of using it, getting back to full range of motion, sometimes, of course, with a physical therapist. With meniscal repairs, it's not uncommon for the surgeon to limit knee flexion for 6 to 12 weeks because the repair is typically in the back of the knee, the posterior horn of either the medial or lateral meniscus. And the thought is if you hyperflex your knee, you might damage the stitches and the repair, and it may not heal the way you want it to. So that is not uncommon for somebody to be limited to 90 degrees of flexion or less, not usually less, but 90 degrees of flexion for the first 6 to 12 weeks. What you would do to get that back, again, I don't know that I would necessarily say there's this exercise or that as much as I would strongly recommend working with a physical therapist to restore knee range of motion. As far as walking, that's not just a motion issue a lot of times, even though if you lack full extension, that can make walking normally very difficult, but it's also a strength issue. I should have said this before, if the issue is you can't fully straighten the knee, that is a much bigger problem. That is, in my experience, very difficult to get back either with physical therapy or with surgery, going in and cleaning out scar tissue. You tend to make a little bit better, but it is very hard to get full extension once it's lost, and it tends to be lost fairly quickly after surgery. So that I was right. Meniscal repair involves stitches. So that's probably the motion. So what I would say, physical therapy, work with a really good sports physical therapist to focus on not just exercises that he or she does, but that teaches you to do at home, and work on them religiously. All right, we're going to have a really quick show today because nobody is asking any other questions. And like I say, all the people I knew that were coming are not here today. So Mike did show up from Nevada. I think were one of the ones that I was thinking was going to come. So Mike, feel free to ask your question. I apologize, I don't remember what the question was from yesterday. While he's doing that, in case we get a bunch more questions, I'll say this now. If you do want to come see me as a patient, again, the information is in the description below, drdavidgeier.com. Triple board certified orthopedic surgeon, sports medicine specialist, anti-aging and regenerative medicine expert. So I can talk to you about all your options, not just cortisone, arthroscopic debridements, joint replacements, that type of thing. So I'm happy to do that. Just contact me. My assistant and I can help figure out getting you here to Charleston, South Carolina. Even if you're not in the United States, we can potentially figure that out. Mike had a meniscus repair. Mike, I really apologize. I don't remember your question from yesterday. Here we go. Didn't give me a brace, told me to walk on it immediately. So it does depend a little bit on. And Georgia, it's good to see you. I haven't seen you in a while on these shows. Great to have you back. So we've got Greece represented today. Not all meniscal repairs need a knee brace and need to be touchdown weight bearing or non-weight bearing. It largely depends on the location of the repair and the nature of the repair. So they're not all created equally. It's probably more common than not to limit weight on it afterwards, but I do know surgeons. I trained with a surgeon that didn't limit weight bearing after a meniscus repair. I trained with 2 others that did limit weight bearing. So there is some personal preference there, but that's not completely surprising. Very nice. Let's see. Partial ACL tear, said it was stable. Knee still buckles. So that is tricky. And Lydia from Singapore, very happy to have you. I can't even imagine what time it is in Singapore, but very glad you joined us, and you're so welcome for the little I did. As far as what Mike was saying, so here's the thing about partial tears, and Mike, I wasn't there, so I don't know what he saw, felt, anything like that. There really aren't many partial tears in my experience. I think of the, let's just say, of all the patients, and I probably saw hundreds and hundreds of MRI reports that said high-grade partial ACL tear. That's a radiology diagnosis. That's what it looks like on an MRI. But 98 out of 100 of those were functionally complete ACL tears. Again, don't know in your case. I wasn't there. I didn't see any of that. But ACLs are like ropes. When they break, it's all those frayed edges. Even if there's some fibers still intact, they're largely stretched out and not stabilizing the knee. Now, you can tell that with somebody asleep. You can do a test called the pivot shift test, and if the knee is essentially dislocated or subluxed and it pops right back into place, it's functionally a complete tear. It's functionally unstable. The other thing that would make me concerned is a patient saying the knee doesn't feel stable. So it may not be, the part that's left may not be doing that much in terms of stability. Now, there are other reasons knees can feel unstable, namely weakness of the muscles around the knee, and that can come back with physical therapy and working really hard on the rehab exercises. But again, I haven't seen, maybe 5 times in my 16 years of operating did I feel that a partial tear wasn't more or less a complete ACL tear. And usually it was only a few fibers of the ACL torn. I've never been all that, I don't get all that worked up about functional or partial ACL tears. The other issue is you can almost always tell on an MRI a partial ACL tear if there's a specific bone bruise pattern. That knee by definition is unstable. Again, don't know in his case if that's what he has, but that's one of those things that you think about. You are very welcome, Mike. The jogging and that may come back. That's kind of hard to say, but whether or not that ACL is doing what it's supposed to be doing to stabilize the knee, I think can be a key question. Somebody from Hong Kong, very cool. 0.5 centimeter cartilage defect, posterior acetabulum in the left hip. Wrong posture of wakeboarding, symptoms for a year. There aren't. Let me explain what that is first, and I apologize, I don't know how to say your first name, but cartilage defect in the acetabulum. The hip is I don't want to go get my model, but it's a ball and socket joint. The acetabulum is the socket. There aren't really great ways to fill that in. Even in something like the knee, which is a little easier to access through a scope, the treatments are not ideal. Microfracture has been shown to not be terribly effective. You can sometimes transfer cylinders of bone and cartilage from non-weight bearing parts of the knee or from donors into that defect. I've never heard of that being done in the hip, even though maybe it has. The problem is I don't know how you could get in there. There's not enough space, even through the scope. I don't know that could be done. Sometimes if it's a loose flap of cartilage, a surgeon might talk about scoping the hip and smoothing that out. I don't know honestly how much that helps. I would probably, my perspective is a little different because I've pivoted my practice a little bit, but I think that's a good potential use of more of the regenerative things, the exosomes, the stem cells, the PRP, maybe BPC 157 into the hip, something like that. Can't tell you for sure that would, by any means, that would definitely fill in. Those are considered experimental, just so you know. But I know there's people out there doing them, and something like that. I don't know that there's a great way surgically to fill that in, honestly. And then Mary, CMC joint surgery, which has less trauma, pain, potential nerve damage, trapeziectomy with a tendon graft, or a silicone or metal implant. So Mary, I will give you my impression, but I will be the first to tell you I am not really a hand surgeon. Not really. I'm not much of a hand surgeon at all. Orthopedics is very subspecialized, and the hand surgeons that's all they do, and then they don't do anything else, and everybody else doesn't do any hand. My understanding from really seeing what patients are going through with hand surgeons I know here is that they're still doing the tendon graft. They take out that diseased bone and cartilage, or diseased bone, freeing up space in the joint and then filling it with a tendon graft. I thought, and again, this may be wrong, I apologize, maybe it's changed in the last few years, that the metal or silicone globes, little fillers, so to speak, haven't worked very well. But a hand surgeon could probably dictate that and tell you that a lot better than I can. I will tell you that is either way, not a huge surgery, but it is a long rehab. The people I know that have undergone the bone removal and tendon graft, it's typically about 12 weeks before they're really starting to even get back to where they're using that hand normally. You are so welcome to you in Hong Kong. Thank you for joining us, and feel free to join us anytime. And so one, I don't give medical advice. This is general information and education only. As far as partial ACL tears and complete ACL tears, yes. And that's even though I don't operate anymore. I do try to help people avoid surgery, but the problem with ACLs typically is that the knee is functionally unstable. A few people can get away with that because their knee basically has enough dynamic stability, muscular stability, that it doesn't give way. But I've seen a lot of people that, it wasn't a problem at first. They really didn't want surgery, and then eventually it started giving way even with pretty mild activities. So yes, I know the field of sports medicine, it's the field I've been in now for 17 and a half years, still says for just about everybody, ACL reconstruction is the way to go. Just know that there are people that can get away with that. All right, that looks like it is it. Thank you so much for joining us today. I hope you have a wonderful rest of your November weekend, and I will see you right back here next Friday. Take care.